Assalamu alaikum مرة ثانية. Let's talk about this next topic, which is multiple sclerosis. All right. All right. Sorry, I'm just sorting things out here on the computer. All right. So, first of all, your definition of multiple sclerosis is basically an inflammatory demyelinating disease of the central nervous system. There is dissemination in space, dissemination in time, and no alternative neurological disease. MS is a clinical diagnosis. Okay, so dissemination means difference. If I say dissemination in space, it means there's the disease is happening in different locations in the central nervous system. So we call it as disseminated in space. Disseminated in time means the disease has attacked this patient at multiple or at different time points. Call it dissemination time. So inflammatory demyelinating disease, CNS, where they're not a slowly progressive course, although there is one variant that is slowly progressive, but generally there's dissemination in space and dissemination in time. And there's no alternative neurological explanation for this. It's true that we say it is a clinical diagnosis, but we do use imaging to make sure it's not any other process. Okay. So it is an autoimmune disease. It affects myelin around the nerve fibers in the brain and the spinal cord. Remember, we have these fibers in the brain and we have them in the spinal cord and we have them exiting the spinal cord going into your arm or your leg, the peripheral nerve. How the peripheral nerve is not involved in MS. Only the central nervous system. Only within the brain and the spinal cord. That part of the nerve where the myelin is involved. All right. So once damage happens here, then you get trouble in transmission and you begin to get neurological manifestations. So it involves the loss of oligodendrocytes. These are supporting cells present in the brain and the spinal cord that are responsible for the production of myelin. In the peripheral nervous system, there's no oligodendrocytes. There's Schwann cells. They produce the myelin. But in the central nervous system, it's oligodendrocytes that are damaged. All right, the T cells recognize myelin as foreign and begin to attack it. All right, explaining why these cells are also called autoreactive lymphocytes. They attack itself. So symptoms, really, symptoms, anything's possible. Anything in the nervous system could be caused by MS. So there's no really one thing that I can say will be MS, but there are some common things. Vision problems are common. Numbness is common. Motor weakness, sexual dysfunction, all of these are common. Changes in bladder dysfunction function as well. All right. All right. Most common progressive neurological disease of young adults. It affects 350,000 persons in the USA. We've got risk factors such as the female sex, being of white race, northern latitudes, living in northern latitudes, high social economic status, and Scandinavian ancestry. So you want to look at the differential diagnosis. A lot of things can look like multiple sclerosis. So like I said, you have to exclude a lot of processes. An infection can look like multiple sclerosis, vitamin deficiency, strokes can look like multiple sclerosis, especially if the multiple sclerosis attack is acute or rapid. Lupus is an autoimmune disease that can look like MS. There could be other connective tissue disorders as well, vasculitis, syphilis, tuberculosis, HIV, sarcoidosis, all of these can mimic MS. So if you approach to the diagnosis of multiple sclerosis, you want to start with your neurological evaluation. And if you got your typical MS findings, then that's it. That's pretty clear. But if you don't have, like you have a person doesn't have any neurological deficits or findings, and they likely do not have MS, but you might want to keep an eye on them if they've got symptoms. But those who have minor or atypical findings, you might need to do more closer follow-up and evaluation. So a lot of these, some multiple sclerosis types are asymptomatic, but the majority is symptomatic, resulting in relapsing remitting course. So relapsing remitting, which is the most common, it occurs in attacks. Somebody is well, they have an attack. They have right leg weakness or paralysis. After 4 weeks, this recovers and then they're fine. May or may not have a residual, but for the most part, they're fine. Then they have another attack somewhere else in their arm, for example. Then another attack, maybe the eye. So relapsing and remitting initially. This is how it starts typically in 85%. Primary progressive is when you do not see that, when you just see a person gradually deteriorating slowly. Secondary progressive is when you've got a relapsing remitting, but then after some point in time, it stops, and then it just turns into a progressive course. And you can have a progressive relapsing. Basically, it's progressive, but you have superimposed relapses on top of it. Right? These are just kind of diagrams that are going to clarify what each one is. All right. So look at the onset of symptoms. A lot of these symptoms are optic neuritis and sensory symptoms. Sensory symptoms that happen the most. So optic neuritis, sensory symptoms, and motor symptoms as well. Some clinical features that are suggestive of MS, usually an onset between 15 and 50 years. We usually don't see it in older people. There might be blurring or double vision, all right? There might be a Lermite sign. Lermite sign is a sensation when the patient bends their neck forward. So they stretch their cord. I'm not talking about dura like we did with meningitis, but here they're stretching the cord. And if there is a plaque or a lesion inside the cord, an MS lesion inside the cord, sometimes call it MS plaques. So if there's this lesion inside the cord, it could irritate the sensory columns. And the person will feel like an electric sensation zapping down his back. Could be even extending into the fingers or toes. So they call that Lermite sign. Fatigue is common, and heat sensitivity. And typically they happen together. They will tell you that I do not tolerate warm temperatures. I need to be in a cold environment. I cannot take hot showers. I really get extremely fatigued. It's normal for everybody to get kind of tired when it's hot or they feel they have less energy, but these people have it, double or quadruple the effect on them. Bladder symptoms. Somebody has urinary retention, urinary frequency, has to go to the bathroom a lot. These are signs. There might be some spinal cord lesions. And sometimes cognitive changes will occur. In early MS, the disease is active and it still progresses even during relapses at times, okay? So I think this one just kind of graph shows you the course over a long period of time. All right, so there's McDonald diagnostic criteria. The McDonald criteria first developed in 2001 and was revised in 2005, revised again in 2010, all right? So requirement of the diagnosis is the objective demonstration of dissemination of central nervous system lesions in both space and time. As we mentioned, you have to demonstrate dissemination in space, dissemination in time, based upon either clinical findings alone or a combination of clinical and MRI findings. So either clinically or through investigations with MRI or even lab tests. So dissemination space. You can do this by MRI. It doesn't have to be, you can only do this often by MRI to see it. Clinically, to see it, you would have to have lesions in different areas. So somebody has leg weakness that you localize on your exam to the spinal cord, and then comes back with arm weakness that you localize to a lesion in the brain. So you clinically demonstrated dissemination in space. But sometimes you can't always do that. So you get the MRI to help you. MRI will show you all the lesions. So if you see if you see one or more lesions in 2 or 4 MS typical regions, then that'll suggest that it is MS. All right. The typical areas are periventricular, juxtacortical, infratentorial, or spinal cord. So this indicates that lesions are happening at different sites. Dissemination in time is demonstrated by MRI by the simultaneous presence of asymptomatic gadolinium enhancing and non-enhancing lesions. All right, let me explain this. So to clinically determine there's dissemination in time, you need time. So a person has a lesion, comes to you with a clinical complaint. After 6 months, comes to you with another complaint. Could be the same one, could be another one, doesn't matter, but there was time. There was time in between. So it tells you that there are 2 attacks, all right? How can you do that by MRI? You use the contrast. The contrast is called gadolinium. Gadolinium enhances MS lesions, will enhance when they are new lesions. So if you see 5 lesions on the brain and you give gadolinium and only 2 of them enhanced, that means, okay, those lesions that did not enhance are old, those 2 are new because they're enhancing. There is evidence of dissemination in time. All right. For patients with 2 or more attacks who have objective clinical evidence of 2 or more lesions, no additional data are required. So this is how you do it clinically. But like I said, you do have to do your investigations. All right. This is just an explanation of what I said. But you can read it. I recommend you read it later. Okay. So when you go to the imaging and lab work, so you have a brain MRI with gadolinium, you have visually evoked responses, you have to do your blood tests, liver enzymes, you want to do Lyme serology. This is mainly in endemic areas for Lyme disease, like in Europe, France, some parts of Northern America, but not here. Here you might actually check for brucella in some cases. ANA, it's fine if there's another autoimmune process, B12, TSH, HIV. You want to check the CSF. CNT spine also, so you can get an idea of the extent of the disease. All right, so MRI flare and T1 with gadolinium. All right, so the top image is a flare MRI, which is basically a T2 MRI, but T2 usually has white CSF. Here they suppress that color, that white color, so it comes out. It's easier to appreciate. So all of these are what we call periventricular lesions. So remember that term. Periventricular means around the ventricle. These are important in MS. You give contrast. You notice that some of the lesions are enhancing, not the whole picture is enhancing. This is a T1 with contrast. And you see some of these periventricular lesions enhancing. So that tells you that there is dissemination in time in this image. But it also shows you the helpfulness of gadolinium. It tells you that this is an active process. Black holes is just a name for well-established lesions. They look black on T1. Don't need to worry about this one. This is a side view, or what you call a sagittal view. Again, periventricular lesions. You see these things coming out periventricularly, it's a sign of MS. All right. And if you look closely at this spinal cord image, right here where my arrow is, there is a clear lesion in the spinal cord. This is a cervical cord demyelinating lesion due to MS. Visual evoked potentials. These will tell you if there's any abnormality in the optic nerve or the optic pathway all the way to the occipital lobe. So it does not tell you where the eye problem is. They'll just tell you there's something wrong with the eye visual pathway. Oligoclonal bands in CSF. So oligoclonal bands are antibodies. These are present in the CSF, but at the same time, you have to take a blood sample because these antibodies will be present in the CSF and not present in the blood. Call them oligoclonal bands. Okay, this is a sign of MS. This is not specific for MS or diagnostic, but highly suggestive. These are some additional variants of MS. Sometimes called the Marburg Variant, Bailos, concentric sclerosis, and Children's disease. Okay, Marburg usually large lesions that almost look like a tumor sometimes. These are rare manifestations. All right, some other disorders that are important to consider. Neuromyelitis optica. Okay, this is important to consider because the treatment is different. Same thing with post-infectious encephalomyelitis. So neuromyelitis optica, this is a relapsing disease and is associated with bilateral optic neuritis. All right. The MRI has cord lesions and the optic chiasm might change. So basically, if you hear somebody with optic nerve or chiasm, optic nerve and chiasm, followed by cord lesions, cervical cord lesions, with a normal brain MRI, you think of neuromyelitis optica, right? CSF usually might have a bit of high white blood cells, but not always consistent. Protein might be a little bit high, and you may rarely see some oligoclonal bands. There might be some post-infectious encephalomyelitis or ADEM. So this happens after an infection. Somebody has some type of upper respiratory tract infection, sometimes after vaccines. And then it's more in younger adults and children particularly. These people are a bit different. They'll present with white matter changes, but they will have fever. They could have seizures during that time. Clinically isolated syndromes. Optic neuritis. So when we say clinically isolated syndrome is when somebody has an event that can happen in multiple sclerosis, but does not fulfill the criteria of multiple sclerosis and had just a single isolated syndrome. So if somebody presents with optic neuritis and that's it, we're going to go look at the brain MRI. If the brain MRI is normal, we'll say, okay, look, you've just had this optic neuritis in one eye, it's slowly recovering, your brain MRI is normal, I don't need to do anything for you right now, I just have to follow you up and make sure you're stable and you do fine. Okay. Might be history of, there might be history of other things, but you want to make sure that the neural axis is normal, nothing in the nervous system. Then you can call it a clinically isolated syndrome. Transversemyelitis. This can be a partial transversemyelitis usually. That means it's not the whole section of the cord. It's just like spots or a certain area and then within the cord. And then you'll get neurological manifestations. This could be just an isolated syndrome, or if there's something abnormal on the MRI, it could indicate this is multiple sclerosis. So management of relapsing, remitting multiple sclerosis. Basically, this is an autoimmune disease. So the management is basically affecting immunity. We don't use something, the drugs we used are not called immune suppressants, but are called disease modifying drugs, all right? Immune modulators. So the acute relapses in MS are usually treated with steroids. You give them a high dose of IV steroids for 3 to 5 days. Engage the response. So their indications for treatment of a relapse would include a functionally disabling symptom with objective evidence of neurological impairment. So if they come to you with clear neurological impairment and it's impaired, you have to give them steroids. It's okay if you don't give a mild case of steroids because they will tend to improve anyways. All right, now the disease-modifying drugs. I want you to look at the class, because on the left it says the therapies. These are all the commercial names given to them by the company. So it's good to know these. And if you look at the class, this is what they are. They're interferons. The top two are interferon betas. One is glatiramer acetate. One is another interferon beta here. And then there's fingolimod and there's natalizumab. These are more heavy hitters, heavier drugs. You want to use these later on, usually after failure of these interferons in the beginning. All right. As you can see, the administration, there's always been a problem with administering drugs. It's kind of inconvenient to give a person injections, like the interferon beta 1A needs it intramuscularly once a week. Interferon beta 1B needs a subcutaneous injection every other day, 3 times a week you're getting an injection. Same thing for glatiramer acetate and interferon here. So Fingo's oral. There are some newer oral medication too that we can use these days. Natalizumab is an IV monoclonal antibody that we use in severe cases. You admit the patient and you have to give them once a month dose. So side effects of MS medication, there's local injection site irritation. If you're taking the injections, the subcutaneous, flu-like symptoms, rise in liver enzymes, decreased white cell count and platelets. Opportunistic infections are much rarer than other drugs. Depression can happen and progressive multifocal leukoencephalopathy with natalizumab. This is a rare infection that happens. It's due to the JC virus. JC virus is present in maybe 80% of us already. A lot of times it's asymptomatically acquired, but it stays dormant in your body and can become active with immunosuppressive agents. One of them is natalizumab. And there have been some few reports additionally with fingolimod, but this will lead to multifocal leukoencephalopathy. So just extensive white matter disease, and it can become confusing to distinguish it from MS at times. All right, fatigue, physical therapy, optimized treatment of MS, get enough rest. Some people try amantadine as supportive treatment. Depression is a common symptom in patients with MS. So there are many drugs that can be used to treat MS. You also want to get assistance from your psychiatrist. Bladder problems are common. To have urinary retention, which is frequent. They might have urge incontinence where they have to get to the bathroom as fast as they can before anything leaks out. Right. So you also want to, when they have this, they have also a tendency to get urinary tract infections. Sometimes there's bladder training that can help strengthen the muscles, or some therapy that can help control the symptoms as well. Okay, I have some of the newer drugs listed here. So with fingolimod, this is one of the newer drugs that we spoke about. It might suppress lymphocytes, unlike the other drugs. It blocks the S1 phosphate receptor. It's probably the first oral pill that was released for treating MS, and is helpful in reducing the relapse rates by close to 60%, 50 to 60%. It shows some benefit on the MRI and the patients. You do have to watch their macula, their cardiac status. In fact, the first dose you give them, you have to give it to them while they're in a hospital to make sure they don't develop any bradycardia, and make sure there's no liver function abnormalities or sudden death. Dimethylfumarate is one of the newer drugs as well. You can give it orally. And it also helps in reducing L rate. This is one of your starter drugs now that you can use in the beginning before going on to the much more heavier agents. Same thing with terraflunamide. Yeah, you can give this tablet once a day, and you might want to also follow liver function tests and CBC to make sure that no complications occur. All right, and these are just some trials discussing the benefit of terraflunamide. And that's about it. So just in summary, I want to say that, MS is an inflammatory disease. It's an autoimmune disease. The manifestations of the disease are going to depend on what part of the brain is involved. So if you have white matter tracts that are coming from the hand center, there will be hand weakness or hand sensory loss. If you have white matter tracts coming from the visual field areas, then you can end up with visual field defects. Same thing, if you have problems in the spinal cord, it will cause you symptoms that are related to that. So there's no specifics. It's kind of like a stroke. Stroke will present with different types of patterns of involvement depending on where the stroke has happened, right? Now, the way to manage it mainly, the more important thing is to diagnose it. Diagnosing it depends on dissemination in space, so it has to happen at different locations, and dissemination in time has to happen at different times. And then you have to rule out anything else with your MRI, and you might need to look for illegal clonal bands in the CSF with the lumbar puncture. And sometimes you do autoimmune studies to make sure you're not dealing with systemic lupus, you're not dealing with sarcoidosis. You might want to do a chest X-ray just in case the disease does have features of other conditions. After that, you want to decide your treatment. For the acute event, you can try steroids. But if there's nothing acute and you want to do long-term management to prevent further relapses and progression, at that point you would look at the disease-modifying agents like interferon or terraflunamide, and the list that I mentioned. Okay, so somebody's asking about treatment. I think that's a good point about the duration of treatment is not well established. With patients, you generally start them on a drug and you monitor and you make sure that they're stable. If people have the longer stability you have, the more reassuring it is. I don't think people will stop drugs in anybody who's got active disease. So if somebody's on treatment but has signs of disease activity happening at long intervals, like every 3 years, they might see a little bit of change on the MRI or clinical change or something, they might will continue with treatment. But if they see the treatment is stopping, they might consider stopping. But if they see that disease has not been progressing, the patient has been fine for like 10 years, for example, on therapy, then you might consider stopping the drug patient and seeing how they do. But there is no single answer to when can we stop the drug. A lot of patients, I tell them, expect to be on treatment for years. Okay. Are there any other questions? Excellent.